which have both shown a reduction in mortality, but in a very select subset of patients. Next. Major Kesu. What is the criteria for administering a patient long-term oxygen therapy?
So if the patient is not able to maintain the target organ saturation,
So what is the target?
88 to 92%.
And what is the PaO2?
PaO2 is more than 60.
Next. So LTOT is indicated if the PaO2 is less than 55 millimeter of mercury or the SpO2 is less than 88. That should be confirmed twice over a period of 3 weeks. Or if the PaO2 is between 56 to 59, then there should be evidence of pulmonary hypertension or the PCV must be increased. That means there must be polycythemia. Next. What is the evidence for LTOT, Dipankar? What are the cornerstone trials that have proven that LTOT has a mortality benefit? Sit. Major Sridharan. What is the basis for giving LTOT therapy?
As indicated, once is this
patient. What are the trials that this is based on? Sit. Next. The two trials that were done in around 1980 were the MRC trial and the NOT trial. In the MRC trial, 15 hours of oxygen per day was compared to with no oxygen, and it showed a distinct mortality benefit. In the NOT trial, the patient was given 24 hours of oxygen versus nocturnal oxygen. In this group, in this study, it was shown that patients who were given continuous oxygen had a better mortality, had a lesser mortality. Next. In moderate hypoxemia, in patients who are at that cusp from SpO2 from 89 to 93, in those patients, there was a trial done called a LOT trial. In this trial, it was shown that usually there is no improvement in mortality. If the patient is for moderate hypoxemia, if the patient is given oxygen therapy, it should only be given for severe hypoxemia. And the last trial is the redox trial. This trial showed compared 15 hours of therapy versus 24 hours of therapy. So this trial also showed there was no difference between 15 hours and 24 hours. Next. These are the trials that there's a select subset of patients who have chronic stable hypercapnia in COPD. So in these patients, domiciliary NIV can be given, but the NIV has to be high intensity and the PCO2 should be targeted. Next. What are the known pharmacological therapies that we should be administering to this patient? Major Satish. Any elements of pulmonary rehab that we should be doing? Exercises?
Breathing exercises can be.
Sit. So the known pharma management includes limb training exercises, management of secretion clearance, smoking cessation, patient education, vaccination, and nutritional build-up. Next. This is a graph showing, called a Fletcher petrograph. It shows the decline in the lung function with smoking. And the dotted line is the one that shows that if the smoking cessation is successful, then the decline stops. The decline reduces in intensity. Next. What are the vaccinations recommended in COPD? Major Akash.
So COVID vaccination, influenza vaccination, pneumococcal vaccination, and the Tdap vaccination in patients who have not been vaccinated previously, and patients elderly more than 50 years, shingles vaccination again.
And RSV vaccine. Next. So the benefits of pulmonary rehab include It reduces mortality as well as readmissions. It improves dyspnea and exercise tolerance, and there's a reduction in anxiety and depression also. Next. How do you manage pulmonary hypertension in COPD? Next. I just want to emphasize on the point that the usual PAH therapy, including bosentan and sildenafil, that is of no use in usually of no use in COPD. The things that help are oxygen therapy, and if the patient has a concomitant apnea, then we can think of giving CPAP. And besides that, smoking cessation and pulmonary rehab. Next. Shamsha, what is LVRS? What are the indications for LVRS?
Sir, LVRS is lung volume reduction surgery, sir. Indications for LVRS will be if the emphysema, if the COPD is on the bilateral apical areas in the upper areas, sir, predominantly, sir. And it is focalized, and if it is diffuse, it is of no use, sir.
ठीक है, बैठिए. So it was the net trial which showed a mortality benefit in patients who had a upper lobe predominant emphysema with a low post rehab exercise capacity. And there are some endoscopic managements also, like endobronchial valve, self-activating coils, and thermal vapor ablation, which can be used to reduce the volume of the emphysematous lung. Next. These are the indications for referral for lung transplant and the listing. Next. The referral criteria and the listing criteria. So what we basically use is the lung function. For listing the lung function, the FEV1 should be 15 to 20%. The board index should be more than 7, and the patient should be exacerbation prone along with pulmonary hypertension. Next.
So the patient's
back. So what are the interventions which have shown mortality benefit in COPD? Major Neetu. Yeah. What else? It is a revision of the sites that we already seen. Na? Okay, next. Back. So go to the previous slide. So in the impact of the ethos trial, the addition of ICS has shown mortality benefit. We have already discussed the long-term oxygen therapy that has shown mortality benefit. NIV has also shown benefit. Besides this, smoking cessation, pulmonary rehab, and lung volume reduction surgery are the ones that have some mortality benefit in COPD. Next.
So the patient's final diagnosis was COPD group E. He was started on DPI fluticasone furoate, umeclidinium, and bilanterol 1-puff OD. He was also advised to continue limb strengthening exercises and to avoid smoke, dust, and fumes. He was vaccinated against influenza and pneumococci and had a written diet plan by a dietitian.
These are the take-home messages. Basically, COPD is a heterogeneous disease with multiple etiologies, as we've already seen, including developmental, genetic, and exposures. The diagnosis of COPD should always be confirmed by spirometry with the FEV1 by FVC of less than 0.7. Smoking cessation and avoidance of ongoing exposures is very important for COPD. And we should always be checking for adherence to therapy as well as the technique of the inhaler on each and every OPD visit. Pharmacological and non-pharmacological therapies are equally important, and both should be stressed upon. And we've already discussed the benefits of long-term oxygen therapy and NIV in COPD. With this, we come to the end of the SCM. Any questions from the residents? Comment from the faculty?
Saket, nicely presented and very comprehensive discussion, Asim. Excellent. Saket, can you just go back to the last slide, please? One more. So this umeclidinium and vilanterol, I don't think we discussed it in the treatment bit. What is
this is a ICS plus LABA plus LAMA. It is available with us, sir.
Okay. So I would like to say that it was a very comprehensive discussion, and most of us as general physicians end up managing a lot of COPD. And so the medicine residents should pay special attention to try and obtain the PPT from Sakat. Overall, very nice. Thank you.
Thank you, sir.
Good Asim, good Sakat. I just want to add 1 or 2 points on this. COPD, we all diagnose day in and day out that a patient who is a smoker has got cough and dyspnea, we diagnose as a COPD. So COPD is not a vague diagnosis. It's a progressive disorder. So once we have labeled a patient as COPD, it's going to stick to him or her throughout life. And as it has been shown that COPD has got multiple etiologies. So we should not take into granted that a patient who is smoker has come with a cough and dyspnea, or who a chula smoker with cough and dyspnea has got COPD. So we should go into history, evaluate the patient, confirm by spirometry, and then only diagnose the patient COPD. Secondly, as we have a habit of starting seroflow furacort for any patient who has got obstructive airway disease, in case of COPD, it has got no benefit. So inhaled steroid should be the last resort. A patient who is not responding to our treatment should be given inhaled steroid, not upfront. Now, as Asim has showed, a patient who is already on ICS LABA, that is on seroflow or furacort, and is stable, don't jump from today onward that stop inhaled steroids, put him on tiotropium. No. Continue that for some more time. Evaluate that patient, repeat spirometry. If patient does not have any exacerbation, the symptoms are well controlled, the spirometry is under control, draw back, start him on tiotropium. Again, stable, tiotropium can be continued lifelong. If we are not giving inhaled steroid, we are not causing more complications of pneumonia, more mortality. So these are 2 points which I would like to highlight. Thank you.
Thank you, sir.
Asim, just one more query. We are a generation who use Derifilin very extensively. So at present, is it completely contraindicated? Is it leading to an increased mortality? Or
Sir, injectable theophylline are out, sir. Even oral also, there's a newer drug, ensifentrine, which is a phosphodiesterase inhibitor, sir, which is a similar drug which has shown some benefit,
which you
but
showed.
theophylline should not be given as COPD, sir, usually. Sir.
If I may add, sir. Derifilin, of course, was the backbone of COPD treatment we used to give to all the patients. As of now, Derifilin has not shown to improve symptoms or mortality. It's only given in patients of COPD group E who have not shown any improvement to ICS, LABA, LAMA, pulmonary rehabilitation, NIVs, and also a supportive weak bronchodilator. In that case, Derifilin can be added, but it increase reflux will cause more complication. So better to avoid.
Thank you, sir. Thank you, sir. With this, we come to the end of the SCM.